I am Dr. Joyce Sequeira, working as a senior professor in the Department of Oral and Maxillofacial Surgery, Yenepoya Dental College, Yenepoya deemed to be university. I am going to speak on mandibular fractures today, and under this we have to learn how to define fractures, narrate the epidemiology of mandibular fractures, brief about the understanding of the surgical anatomy of the mandible, clinical features, radiological features, and the management of the mandibular fractures. So, fracture is defined as a sudden break in the continuity of bone which may be complete or incomplete in character. Fracture of the mandible occurs frequently compared to other bones because it is a strong bone, and it is 4 times the force required to fracture the mandible when compared to the maxilla, because maxilla is very soft and mandible is very hard to fracture. It has got so many innovations like by the mandibular nerve, and this nerve comes out from the foramen ovale, and then inferior alveolar nerve goes through the mandibular foramen and then supplies the nerve, all the teeth as well as the mandible, and from there it comes out to the mental nerve. And blood supply is by the facial artery mainly, and to the particularly to the mandible it is from the inferior alveolar artery and the mental artery and the periosteal attachments. So, factors which influence in displacement of the fracture are direction and the intensity of the trauma, and site of fractures, and then direction of the fracture line, muscle pull exerted on the fracture segments, presence or absence of teeth in the fracture line, and extent of soft tissue wounds. Coming to the etiology, road traffic accidents, assaults, interpersonal violence, fall, sport injuries, industrial mishaps, work accidents, and of course pathological fractures will lead to mandibular fractures. And general classification by Kruger in 1974 states that it is a simple fracture, compound fracture, comminuted fracture, complicated or complex fracture, impacted fracture, green stick fracture, and the pathological fracture. Simple and the closed fracture is not communicating with the exterior. Like most of the time, condyle or coronoid is a common closed fracture or a simple fracture. Compound fracture is there will be a breach in the mucosa or in the exterior skin, because it is called as compound as some dirt will get into the fracture area. And next is the complex fracture, is involvement of the nerves, blood vessels, and involvement of the joints etc. will lead to more complications. So, that is why it is called as complicated fracture. It is shown in the picture, the simple, compound, and the comminuted fracture. And green stick comminuted fracture, shattering or fragmentation will be there, and green stick fractures they are incomplete, seen mainly in children, and impacted fractures one fragment gets into the another fragment, and pathological fractures mainly because of malignancies, benign tumors which is eaten up the bone, and then it will land up in fractures. Next classification is Dingman's. It is according to the site of the fracture, condyle, ramus, angle, etc., alveolar bone fracture, symphysis, parasymphysis, body fracture, according to the anatomy of the mandible. And third is classification of the angle of the mandible is basically based on the displacement of the angle. It's called as favorable or unfavorable. Favorable we have horizontal and vertical, unfavorable we have horizontal and vertical based on the radiographic views. So, horizontally favorable and unfavorable is basically the muscle attachment and the line of fracture. When we see from the horizontal view, the fracture line is going most posteriorly in the mandible, and in the alveolar portion above, the masseter muscle displaces it, then you call it as unfavorable. And if it does not displace, because there is a hindrance from the dental segment, then you call it as a favorable. So, the classification actually decides the management of the fractures. So, we have to think about the management in a different line when it is favorable and unfavorable. So, vertically favorable and unfavorable, you go for X-ray which is lower occlusal, or a PA view of the skull or mandible, and then here the medial pterygoid muscle pulls the posterior segment medially. If there is any dentate segment or the fracture line is oblique, then it may not pull it medially. So that is how you call it as a favorable and unfavorable, as shown in the picture. So clinical features, general and specific. We have general clinical features are swelling, pain, drooling of saliva, patient will not be able to swallow, tenderness all over, bony discontinuity, step deformity, lacerations on the face, limitation in mouth opening, ecchymosis, fractures, subluxated and luxated teeth, bleeding from the tooth or intraoral site, etc. will be there. And then specific features are symphyseal or parasymphyseal fractures. There will be tenderness, especially in the parasymphysis region, and sublingual hematoma is very classic, and loss of tongue control. Patient cannot pull the tongue out or pull it in. So because of the attachment of the genioglossus and geniohyoid, that muscle, this tongue gets its control lost. Soft tissue injury to the chin and the lip is very classic in case of symphyseal or the parasymphyseal fractures. Fracture of the body of the mandible, there will be swelling, pain, tenderness, step deformity. If there is a nerve injury, then there will be a paresthesia of the lower lip, because the mental nerve supplies the lower lip, and there will be intraoral hemorrhage if it is a compound fracture. And fracture at the angle of the mandible, there will be swelling, posterior gag, deranged occlusion, paresthesia of the lower lip, there will be hematoma, step deformity behind the last molar tooth, tenderness, trismus, mainly because the muscles of mastication are involved. This kind of trismus is seen in case of fracture of the angle. Fracture of the ramus, there will be swelling, ecchymosis, pain and trismus. If there is any involvement of the masticatory muscles, always there will be trismus, irrespective of whether it is fracture or an infection. Coronoid fracture, tenderness over the anterior part of the tragus, hematoma, painful limitation of the movement and protrusion of the mandible may be present. So clinical examination, history taking, we have to take the history, how the patient had a fall or how it happened, whether there was any loss of consciousness, etc. Then how much blood loss, anybody witnessed it, all those things we have to take it in the history. And then extraoral examination, we have to inspect properly whether there is any swelling, laceration, hematoma, ecchymosis, abnormal mandibular movements are there. Palpation, you have to see the tenderness, step deformity, mobility, crepitus, joint movements are proper or not, paresthesia is there, all those things. And intraoral examination, we have to see basically the occlusion and inspect the occlusion, laceration, ecchymosis, occlusal step, derangement of the teeth, etc. And palpation, we have to see mobility of the teeth and crepitus, whether there is a mobility of the fracture segment and tenderness, etc. we have to see, very important. Then coming to the investigations, we have to go for the radiographs basically here, that is OPG, PA view of the mandible, occlusal view, reverse Townes view and the CT scan. So managing, we have to go for preliminary treatment, reduction, fixation, immobilization and control of infection and rehabilitation of the function, very important. So coming to the management, airway, first of all we have to see whether the airway is maintained, whether the patient is breathing well, oxygen saturation is there or not. So the reasons for airway blockage may be tongue falling back, if there is bilateral parasymphysis fractures or blood clots clogging into the throat, fractured teeth segments, broken fillings and dentures, and hemorrhage, soft tissue lacerations, support of the bone fragments and pain control, infection control or compound fractures, or nutritional support is there not, patient is taking any oral fluids or not, all those things we have to see before getting into proper management. So what are the general principles in the management of fracture? That is, first of all we have to reduce the fracture, fix it and then immobilize it and rehabilitation. In case if you are not going for a open method of reduction, then we have to do the reduction with the help of immobilization. So, reduction is restoration of the fractured segments to their original anatomic position. So, under the close reduction we have manipulation, and then in the close reduction we have to put the patient on IMF, that is intermaxillary fixation, put the arch bars or eyelets or the IMF screws, and then tie up the upper and the lower jaw in proper occlusion. So, here in close reduction, occlusion is the key of reduction. We are not opening the site of fracture, but arbitrarily seeing the occlusion, we presume that the fracture segments are reduced, and we have to keep them in that position for a period of time. So, indications for close reduction are non-displaced fractures, grossly comminuted fractures when there is multiple fragmentations, edentulous mandible, and mandibular fractures in children with the developing dentition, and coronoid process fractures we go for normally close reduction. But there are certain contraindications. For example, in alcoholics, those who are having seizure disorders, convulsions, mental retardation, and nutritional concerns, and COPD, respiratory distress, and then of course unfavorable fractures. So, arch bar wiring we do for the upper and the lower, and we put the patient on IMF. So, period of immobilization is especially if the tooth is removed in the fracture line, then it is 3 weeks fracture of the body of the mandible and the early treatment. All these things in adults, it takes 3 weeks for the immobilization and fracture fixation, or rather fracture healing. So, tooth is removed in the fracture line. If then tooth is retained in the fracture line, add 1 week, fracture at the symphysis add 1 week, age 40 above add 1 week, and children definitely you have to subtract by 1 week. So, open reduction, you open up the fracture under general anesthesia and then see the fracture directly through the eyes, and then reduce it by manually and putting the patient on intermaxillary fixation and fix the fracture with the mini plates. So, approaches to the fracture site, extraorally we can go and intraorally we can go depending on the fracture site, that is existing laceration, residence incision and hinge incision we go extraorally, and intraorally in the vestibular incision. Fixation devices basically for rigid fixation. What is the meaning of rigid fixation is we need not put the patient on intermaxillary fixation and it is rigid. Semi-rigid fixation we may have to put the patient on intermaxillary fixation even after fixing it with these devices. So, rigid fixation devices are lag screws, compression plates, under that we have dynamic compression plates and eccentric dynamic compression plates, and we have recon plates. And under semi-rigid fixation we have conventional mini plates which are commonly used because of the cost factor, and transosseous wiring also we can do. So, these are the plates which we use for the mandibular fractures, and this is how it is used. There is Chamfy's osteosynthetic line. In that line we have to fix the mini plates to get a proper response, or it corresponds to a course of a line of tension at the base of the alveolar process. This is the ideal osteosynthetic line, and there are bioresorbable plates as well which resorb over a period of time, polydioxane, polyglycolic and polylactic. So, use of these is very limited because of the strength is inadequate, and then it is very economically highly cost. So, that is why this is not being regularly followed. And lag screws, they have very good rigid fixation ability and less of hardware, more cost effective, and rigid method of internal fixation, insertion is quicker and easier, reduction is more adequate. And then we have recon plates for rigid fixation. Here also stabilization of the entire comminuted complex can be achieved. There are multiple fractures and we need not go for the multiple plates here, single plate will take care of everything. So, now coming to the summary. So, mandible fractures are most common after the nasal fractures. because of the position of the mandible is like that, and which results in inability to open or close the mouth. Restricted mouth opening will be there, pain, swelling. We can make out that there is a fracture of the mandible. Patient will not be able to eat at all, open the mouth, etc. And fractures may be reduced by closed or open method as described in the slides, depending on the indication. Immobilization is achieved by intermaxillary fixation using arch bars or different wiring techniques as described. Thank you.